Good afternoon, everyone. This is Michelle Norton, Senior Vice President of Marketing at CO Health Analytics. On behalf of CO and NHCAA, I would like to welcome you to today's webinar, Advanced Pharmacy Analytics, Enhancing Fraud, Waste, and Abuse Compliance and Cost Containment. Today's session will discuss how advanced analytics can reduce costs for PBMs and health plans, as well as help maintain the integrity of the pharmacy benefit. Topics today will include member drug-seeking behavior identification, pharmacy report cards, and medical versus pharmacy claims comparison. Our speaker today is Rena Belinsky, PharmD Senior Vice President and Chief Pharmacy Officer at CO Health Analytics. Rena has worked in healthcare for 26 years and has been with CO for the past 10 years. Her experience includes managing the operations of both national and regional home infusion, home health, and DME companies. She has developed and managed audit and analytics programs at CO that focus on specialty pharmacy in the medical and pharmacy settings, as well as retail pharmacy. Before I turn it over to Rena, I'd like to review a few brief logistics. Attendees are in listen-only mode. You can submit questions at any time during the presentation via the question module in the GoToWebinar panel on the right of the side of your screen. We will have a question and answer session at the end of today's webinar, but please do feel free to ask those questions as they arise. The session today is being recorded and will be available to attendees after the session. Finally, there will be several interactive polls during the session, so we encourage you to participate in these polls as part of the session. Without further ado, I'll turn it over to Rena.
Okay, great. Thank you so much. Good afternoon. Can you hear me okay?
Yep, perfect.
Okay, fantastic. Well, good afternoon to everyone and good morning to those on the West Coast who have joined. Very pleased to be with you this afternoon and this morning. So today, as Michelle said, we're going to be talking about a few analytics that we have developed in line with some of our client expectations and client needs that we have been working with them on. We know there's a lot of analytics out there. We wanted to share those that we've put together that we developed in collaboration with both our health plan and PBM clients. Some analytics can be quite overwhelming, and our goal was to develop those that are fairly focused and targeted and are manageable and also will provide actionable information for our clients. So with that, the goals of today's session will be to talk through some of the recent concerns that the OIG identified with the integrity of Medicare Part D as it relates to opioid usage and trends, as well as some pharmacy trends that are pretty interesting. Spend some time on how we can integrate medical and pharmacy data as well, and then discuss some of the challenges that we all face with data and data analysis, address some ways in which we feel we can assist our clients with those concerns with data, and then of course answer any questions that you might have. So the more relevant points of reference for these topics that are available to you in the back of the deck that we're presenting today, but in June of this year, the OIG published a couple of reports, and they were a bit concerning, and they're in regards to expressing concern about the integrity of the program, specifically related to fraud, waste, and abuse. So the statistics here, when Part D started in 2006, you can see that the spend has more than doubled. There is a particular increase in the spend of commonly abused opioids, and these are based on as compared to national averages, so just so everyone's aware of that. We know that there's a big increase in population, the baby boomers and the aging population, so that spend does have something to do with the increase in number of beneficiaries And just as FYI, I might be referring to those as members also, but also the average number of prescriptions per member or per beneficiary, and sort of a increase in the opioids growth versus all other legend drugs. So we'll be spending a little bit of time on that. Again, the two reports, one was a portfolio and one was a brief, but one of them focused on questionable billing and geographic hotspots, which I've outlined here. So in terms of the highest dollars spent per member for opioids are in the states listed here. I don't think any of these are a surprise to most of us who work in the space of FWA and pharmacy and member abuse. And then the highest proportion per beneficiary are in several states as well. And then CMS concluded that there are some holes, if you will, in the program itself. Lots of things are improving, which I'll talk about as well, but the bullet points here were basically a summary of the report that the OIG published, and they talked about the fact that, you know, one of the interesting things is that the CMS doesn't require plan sponsors. It's not mandated to report fraud, waste, and abuse, for example, and I think the most recent year reported was in 2012, and only about 35% of plan sponsors are reporting voluntarily, you know, fraud, waste, and abuse. So that's a concern. There's a lot of discussion as well, which I'm not going to go into today, but are cause for concern, and there's a lot of movement as it relates to invalid prescriber IDs, excluded providers from the OIG list, refilling of Schedule II drug medications, and then also, which we've all heard about, is you know, prescriptions being filled and paid for deceased beneficiaries. So that's all contemplated as well in the brief. So I just wanted to mention that as well. They also reported the medic is not taking advantage of all data available to them. CMS and the plan oversight, the OIG is saying it's not at this time sufficient to protect the Part D benefit, and they haven't, CMS hasn't leveraged all the tools available to them as well. So basically, you know, in summary, it remains vulnerable to the member, pharmacy, and prescriber fraud, waste, and abuse, which, you know, is the focus of the topic of the conversation today. So, you know, whether you're a health plan or a PBM, whatever your membership is, if you're 20,000 members or 2 million members, you're faced with, you know, a lot of information coming at you, and some of you might be wondering, you know, where do we start? And so we have put together some analytics that we think can assist with that. So with that, Michelle, I will turn to you. This is going to be our first poll question. It will be fairly quick, that you should be able to see on your screen, and we'll be asking you just this one question, and if you could provide your responses.
Great, thanks, Rena. So as Rena said, please respond to the first poll question, and I'll read the responses out here for folks. We really want to get a sense for the audience and where you are with your analytics processes. So the first question is, how effective is your current analytics process to track and analyze member drug-seeking behavior? So A is not effective. B is partially effective, meaning the data is available but analyzing is complex. C, completely effective. You're able to analyze and visualize data easily and take action upon that data. And D, not applicable. You don't currently have a solution where you're using analytics for member drug-seeking behavior. And it looks like we'll give everyone just another second. We have most folks voting. Give folks another second or two. And I'm going to close out the poll and share those results. And it looks like the majority of folks, about 46% of you said partially effective, that you have data, but analyzing is complex. And that's followed by about 23, 24% equally saying it's completely effective and some saying not applicable. So it seems like the majority are in the boat of having data, but it's pretty complex. So let me turn that back over to you, Rena.
Okay. All right, thank you. That's great to know, and it's fairly consistent with what some of our health plan clients and PBM clients are telling us as well, that they get some data. Sometimes it's a bit overwhelming. Sometimes it's too much to handle. Sometimes it's not exactly what they need. So we've designed ours to be, you know, again, more user-friendly, and which we'll get into, but also pretty specific to what a client would be looking for. So from the member perspective, the reason we all, I think, agree and feel that this is important from an ROI standpoint of, you know, looking at member specific and drug behavior, drug-seeking behavior, and opioids, the savings and the spend are pretty astronomical, and that's probably not new to most of you who are participating. But if a member can be identified as potentially drug-seeking or abusing or committing fraud or in collusion, the statistics are all fairly consistent and fairly clear that, you know, it can be either for, you know, every dollar in pharmacy spend, $50 can be saved on the medical side. Other statistics say an average that over $1 million can be saved on the medical side in cost savings for that member that is identified and some sort of action takes place. So those numbers can come from, you know, decreased emergency room visits, office visits, and things like that. There's some statistics here that, you know, the number of ER visits due to opioid abuse, improper use of legend drugs is fairly outstanding. Inpatient admissions are, you know, pretty high as it relates to, you know, overuse of some of these drugs that we're discussing. Of course, from a pure clinical and safety perspective as well, you can identify members who have perhaps a clinical overlap if they're going to different prescribers, unknown to those prescribers, and getting drugs of a similar class, and there's a potential clinical or safety issue. So we can identify those as well. And then, of course, you have the ability to reduce your exposure if there's just true fraud or collusion taking place. So from a member drug-seeking behavior, this is the dashboard analytic that we are providing. This is, it has a lot of detail. We're going to try to get to the highlights for this specific session. But this would be the dashboard that has a lot of information. You can see here we have done some analysis of the analytics, so to speak. So we have folks who work on this that understand the drugs, the industry, what needs to be floated to the top in terms of what members we want to take a look at first, and things like that. So we do not make any assumptions on what your data should be. We take your data, we do some benchmarking. I think there's a lot of folks that we've worked with through the years, especially from a fraud perspective and as it relates to a member, typically use like what we call a 10-10-10 rule. So a member goes to 10 pharmacies, gets 10 prescriptions, and goes to 10 prescribers. We would not make any assumptions that that's the benchmark of your particular member population. So we first run that benchmark, and then we do some stratifications or analysis by some of these items here. So we're looking at therapeutic class, the DEA schedule, pharmacy chain code, you know, what's the member's age. If we get prescriber specialty, we like to look at that. What's the line of business? We're not focusing on 5-year-old members here necessarily. We look at the carrier or the client for our particular client, if that's applicable. If we get the diagnosis, one of the important things is the pharmacy type or dispenser type. Is it a compound pharmacy? Is it a specialty pharmacy? So, and then we refresh that benchmark on a monthly basis so that we are keeping in constant update to what that member population is looking like. And then we also track previously identified members on the dashboard so that if a member had been reported, say 2 months ago, and it's 2 or 3 months later we're providing the report, we can give a status on that member. We can show if there was some sort of intervention on that member. Do we truly see a decline in spend? Do we see that they've not gone to as many pharmacies or as many prescribers or have gotten as many prescriptions? So our report was designed, again, with client feedback to be very visual, also somewhat interactive. So you're getting something that, you know, is not like PDF. It's something you can sort and filter on. It gives you a little bit more ability to kind of say, okay, this looks interesting, so what if I want to, you know, look at this or that? So we like the fact that it's a little bit interactive as well. Again, we're analyzing the analytic for you, so we're trying to weed out those false positives, so to speak, and identifying just those members that we feel would be of concern to you. So the visual display is really nice. We'll get to that, and we'll take a look at that. And again, we're going to be tracking the fraud aspect, a clinical safety aspect. The other thing that we've done, which is fairly new, is we're pulling in consumer data on that particular member and their zip code. So what is their income level, education, so that if you're a PBM, for example, you can help your client to say, here's some information and background about that member's geographic location, if there's going to be, you know, any counseling type of intervention or anything like that. It's a little bit of useful information. So now we're at the dashboard slide. And again, you can see we've got the top members here. You're able to filter on each of these members. You can see the various metrics here. So this one in particular, so this particular member, you know, went to 8 unique pharmacies, 8 unique prescribers, and got 19 unique prescriptions. So this would be highlighted as a member of concern, and then potentially looking at all of the other indicators. So what were the therapeutic classes? You can see what is the line of business, what is the member's age. If you're a PBM, what is the carrier here? So we're looking at that. The DEA schedules are here as well. We also include the dollar amount and the copay information. We feel that that copay can be important. It might show that a member is, you know, paying. Obviously, we can't see cash paying patients, but we can see where somebody's paying a higher copay than normal, just, you know, to be able to get their medication. And then on this slide, we basically take the member information, and again, we're benchmarking over the entire population. So for this particular month, on this particular client in this particular age bracket, again, that stratification is important to narrow down to what you need that is useful. So in this particular month, 2 members went to more than 10 pharmacies, and then 2 of those members more than likely went to, you know, more than, of these 2 members, there were 144 that went to more than 10 physicians. So this is where we start to kind of slice and dice and get down to what are the true members that we want to go target and take a look at. And then our visual map, which is, it's all going to be in the same report here in our reporting layer. So you can see we've got different tabs here, but the map itself, which I'll zoom in here, shows in relation to the members. So we're kind of showing that, probably I wrongly call it the axis of evil, but kind of this triangle of where is that member in relation to the prescribers and the pharmacies. So you're able to very quickly see where are they driving to, and there's other tabs that show the mileage and those sorts of things, and those can all be exported and available. But again, from a purely visual perspective, this gives you a very quick glance. You know a lot about this member already. What drugs are they on? What's their line of business? What's their age? Again, if we have the diagnosis, it's going to be there. And do we think this is legitimate, or is it of concern? So some that we have, we see, your typical snowbirds. We know that those are probably not somebody of concern. That would be, somewhat of a false positive. And then we have seen where members are driving across state lines. That could be of concern if it's not legitimate. So we look at that as well. If you can drill down into the drugs, there are certain disease states, of course, as we know, oncology, some of the autoimmune diseases where getting a lot of drugs going to several different prescribers does make sense, and that's not something we would want to be concerned with, or those might be legitimate members. So from a regulatory standpoint, I felt it prudent to mention a couple of House and Senate bills that are in the works. If you've not heard these, I was aware of the House bill. I just recently learned about the Senate bill. But there is a House bill that passed in May of this year, and it does allow for a lock-in of a Part D member. This will have to go to the Senate now to get passed. So we'll all be staying tuned on that one. And then the Senate bill was also introduced in May. So a different bill has been introduced, and that one is just introduced. It's not been passed. It's only been reviewed, I think, twice. But you can look these up and see the status at any time. So for some of us that were involved early on in the MEDIC initiative, so before CMS took over managing some of that process, when the MEDIC meetings and those quarterly meetings we had were sort of a grassroots type effort, you can see it's taken a long time to get here. So with the benefit starting in 2006, anytime there's a benefit, I mean, the fraud comes after. So around in 2008 is, I think, when we started seeing that, and the informal MEDIC meeting started meeting. And so again, it's just been so many years since a lot of us were, asking for this lock-in capability. It exists on the Medicaid side. It was not available to us on the Part D side. So this is, really fantastic news. I mean, we'll see how long it takes. But the key here is when these do become a law, we want you to be ready to act on those members that you've identified. The Senate bill has a little bit of different language in terms of it requires physician training. It requires some incentives actually of getting money if they are willing to, physicians are willing to report mortality rates due to an opioid death. So that one has a little bit of a different spin to it. The House bill is sort of and highly administrative, and it will be some work to get that member identified, and there's a lengthy process to document everything and to get that lock-in, but nonetheless we'll at least have that lock-in available to us. So you kind of would want to start laying the groundwork for how would you do that once this is going to be available to us from a regulatory perspective. So sort of switching gears a little bit to the pharmacies, the same OIG report also did express some concern. There's roughly 70,000 pharmacies in the United States and growing. We learned that there's those top, 1 to 2 to 3% of pharmacies, and it's the same with members and same with prescribers. Those are the usually tough ones to identify, but we're seeing, again, an increase in all of these measures, number of prescriptions per beneficiary. A lot of those are commonly abused opioids, the average number of prescribers, the types of drugs, excessive supplies of drugs was found to be an issue. There was also an identification of some certain hotspots. I don't think any of these, again, to those of us in the fraud world, are new. A lot of these drugs are not new. These are non-opioid drugs that are, billed specifically for diversion and collusion. So this is good information to know, but we all know that new pharmacies are consistently popping up. New billing is consistently constant. So the key is to really be monitoring your own data and identifying these types of things before CMS comes in months or years later to let us know, hey, here's what our findings are. So we want to catch this as it's happening versus retroactively. I mean, if we're not looking at our populations, they're on to the next scheme by now already for sure. So that's what we want to make sure we focus on. So as it relates to pharmacy reporting, report cards or a scorecard, we're going to be doing another quick poll. So Michelle, I'll turn it over to you.
Great. Thanks, Rena. And I just launched that poll. So if you can all take a second to answer this question, what is the impact of your current pharmacy report card? A, it's not effective. You're not able to analyze or visualize pharmacy data today. B, it's partially effective. Data is available, but analyzing and visualizing the data is complex. C, it's completely effective. Analyzing and visualizing the data is easy, and you're able to take action on that quickly. And D, it's not applicable. You don't have a current solution in place for a pharmacy report card today. We'll give you a couple seconds. Looks like about 60% of folks have voted. So take a second, please, and help us better understand where everybody's at. Okay, I'm going to close out the poll and share the results. And actually, pretty close tie here. About 43% said they don't have an analytics pharmacy report card today, and 34% say they have one, but it's partially effective and the data is available but complex. So Rena, I'll turn it back over to you.
Okay, thanks everybody. Okay, so I think all of us know pharmacy scoring and report cards are not new in the industry. They've been used for a long time. But like the members, we do a similar profile or benchmarking of the pharmacy network of whatever client that we have. We first kind of take a look at the network and say, okay, what does it look like for maybe a span of a year to kind of get our baseline, and then on a weekly basis thereafter we do a benchmark as well. And then we have several metrics which I'll talk about for those pharmacies that seem to be fairly industry standard, but we'd like to continue to make that better. So we work closely with our clients to get that feedback on how we can improve the scorecard. We assign an overall Z-score, which I'll show you in a little bit, to each pharmacy as well. The dashboard and the report was assigned, again, to be user-friendly, easy to read, and we're using a red, yellow, green light for each metric and for the pharmacy scorecard to be able for you to visually see right away what pharmacies do I need to concern myself with for this week. You have the ability to sort on each metric. We're also identifying new billing, which we'll be able to show you here as well. So this question was in the wrong. I'm going to go past that. So in the metric of, or the list of metrics for the report card, these are the metrics that we're currently looking at today. We can add and delete these based on client-specific needs. The key here is that it's done weekly so that it is very proactive. Personally, and ideally, I would like to do this daily for our clients. We've had situations with some of our client partners who have had exposure as it relates to a particular pharmacy. For example, if they have a new pharmacy come in and bills a lot of compounds for a month or two and then closes up shop and goes away, and they're not able to catch that, so they're out, X amount of hundreds of thousands of dollars. We've had another situation where a new standalone PDP a client came into the network of pharmacies and started billing, for example, 10 prescriptions per member per day every day. So it was clear fraud, clear diversion, but it was not caught because things like this are not being looked at on a daily or weekly basis. So given the fact that these pharmacies are, opening up, their NPIs are changing, nominee owners are coming in, it's really hard to keep up with this. And so the data is going to tell your story, and we feel it's very important to look at this on a really super frequent basis. So this is what the dashboard looks like. We've got a lot of information here. You can sort of see across the top the various metrics that we're looking at, and then we have a couple of, I guess, major stratifications or filter capabilities. The goal here was to give a lot of information but not be overwhelming, but still allow you to say, okay, this might look high, but I know because of the pharmacy type that's acceptable. So, or if Walgreens has, a high or low generic dispensing rate, how does it compare with the other Walgreens? Because Walgreens might be asking you that. So we've given the ability here to filter by affiliation and also by pharmacy dispenser type, because we feel that's a pretty critical component. And then here, sorry, I went too fast. So the new billing, you can see you can sort on each of these buttons, and so this one's been sorted on the new billing. So these pharmacies for this week have new billing as compared to last week and the entire length of time for which we've been tracking this particular pharmacy network. So this pharmacy has new billing. It doesn't have a Z-score yet because they've recently been introduced. So again, we're trying to quickly hone in on what pharmacies do we want to take a look at. The dashboard would show if there were a high Z-score, which in the case this pharmacy has one, has high, cost per ingredient, cost per RX. You can see this is a pretty high one. They had a lot of claims in that week. We feel this should be looked at as compared to the prior week or prior weeks in which that pharmacy has been billing into the network. Now, the other thing that's flexible here is some of our clients might have told us, for example, the weekly is too much. We don't have staff or bandwidth to look at this every week. It's too much information. So it can certainly be done monthly. So these are pretty flexible in how they're designed, and we did that on purpose so that we can meet our clients' needs. And then this just shows the red, yellow, and green light are based on the deviation from the benchmark for that pharmacy population. And each of these metrics can have a defined deviation that's acceptable, and the overall pharmacy can have a defined deviation. And we work with our clients per metric to determine what is acceptable to you for that particular metric or pharmacy type, for example, that would be considered to be when it deviates from that benchmark, I want to know about it. So what percentage? So if it's, if it's 5% from the average pretty consistently, we're not going to be too concerned. But when it spikes up or down on a certain metric, we know that we're going to, be concerned with that. And then the new billing allows you to quickly see. You can also export this to monitor new pharmacies coming into the network. We'll be adding city and state and affiliation to this particular report. But we feel like this is nice because it gives you some reporting capabilities to be able to see the new pharmacies that have come into the network. And then we also provide you with that benchmark information for that particular pharmacy. So if you've selected a particular pharmacy and now you want to look at the detail of each of those metrics, we have that available as well. So the blue bar graphs here represent that individual pharmacy week to week, what their percentage was for that particular metric. And then the green line is the benchmark for all pharmacies. And then the red line shows them as they are compared within their affiliation, if that would be applicable. So for an independent, potentially they might not have an affiliation. So we're showing you that as well. So from a ROI and benefit perspective, we feel that the benefit is that we know CMS publishes watch lists. We can incorporate that into the report card as well to say, hey, this is flagged as on a watch list, so we want to watch it too. It can allow you to create your own internal watch list. It allows you to do some early intervention. So if you see a pharmacy that's potentially questionable, you can pen claims, potentially do some due diligence on that pharmacy, maybe try to get somebody out on site if you can, if they're close by, request some copies of prescriptions just to validate what the report is saying to really try to limit your exposure. It can allow you to place pharmacies on corrective action, and then of course if a pharmacy is terminated from a network, there can be some cost avoidance there. And obviously you're only going to terminate after you've done some due diligence. So now we're going to move on to pharmacy versus medical comparison. And this will be just a quick overview before the last poll question. But we have an analysis that compares medical billing to pharmacy billing, so a HCPCS to a J-code to identify overlaps in billing and payment for drugs that are submitted under both. Unfortunately, as claims systems exist today, that's something that is allowed to happen. It's termed double dipping. It's a fairly common practice, again, not new, usually not intentional. Sometimes we've seen it as intentional, but typically it's not. It's just the nature of the fact that a drug can be billed into both types of benefits. But we look at all areas of drug submission, so we're not just looking at professional claims, for example. We're looking at mail order, specialty, and all of that as it relates to the medical side. Again, these avenues allow for, they don't communicate all of those claim systems. So, but one of the things that we do differentiate, I think, from others is that we take a look at the proper dosing, the length of therapy of the drug, the dates of service, the units, the benefit information, so that we can give you some guidance on, once we identify a billing, what would you do next? So with that, Michelle, I'll let you run the next poll.
Okay, great. So as Rena said, this is our last poll. Thanks for participating in them. For this question, we'd like to know, how do you compare medical and pharmacy claims data today, and what's the impact of that process? So response number A, letter A, is internal process with limited impact. B is you have an internal process with significant recovery. C, you use a third-party solution with limited impact. D, a third-party solution with significant recovery. And E, you don't currently measure or analyze medical versus pharmacy claims data today. So we'll give everyone a few seconds more to respond. Thanks for participating. Looks like we're at about 60%. I'll give everyone another second here. Okay. Looks like the answers have tapered off, so I'll close the poll and share. And it looks like the majority, with 45%, do not have analytics in place for comparing medical versus pharmacy claims data today, followed by about 30% that use an internal process with limited impact. So Rena, I'll turn that over to you.
Okay, fantastic. Thank you. So just to give a quick background to explain why some of our clients do have difficulty in comparing a pharmacy versus medical. I picked this particular injectable because it's A, fairly common, and B, we find a lot of overlap with it. So Lovenox, which is a common injection for blood clots, typically post-surgery, has a J code or HCPCS code of J1650, but that drug itself has 23 different and unique NDC numbers. So on the medical side, this drug is billed, and you would see it on a claim, and you would not necessarily see what the dosage is, what the strength is, what the formulation is. Is it a pre-filled syringe? Is it a multi-dose syringe, et cetera? So it's a very broad code as compared to a very distinct NDC. The NDC has the manufacturer. You can see some here are generic, some are the brand, some are pre-filled, some are multiple fills within a syringe. So there's a lot of different NDCs that can be associated with that particular HCPCS. And then a report that would come to you would look something like this, where we've taken at the member level, we do that crosswalk between the HCPCS and those NDCs and identify where there's an overlap in the billing. We show the span of days of that billing. I think I blew one up here. So this one you can see on, and this one was sort of interesting because it's an oral medication that was billed on the medical side and on the pharmacy side. But based on the quantities, which actually are not shown here, but you would be able to quickly identify, hey, this is being paid for twice, essentially. So, and then here's an example where, and again, just to show the complexity of how a drug is billed. So on the medical side, we've got, let's say, a patient's getting Lovenox twice a day for 7 days. Excuse me. So they received it in an outpatient setting on the medical side, 84 units, which is the correct number of units to be billing. And then they also received it on the pharmacy side. Perhaps it was mailed to them from that particular member's plan benefit, which has a specialty pharmacy and had gotten a prior authorization, for example, and submitted and mailed the drug, let's say, for example, to the patient's home. So in this particular instance, we can see based on the quantity billed, the paid amounts, this is more than likely a duplicate where a health plan can recover because it's essentially been paid for twice. So we hope that that example is helpful to you. And then another example where something would be valid, where there might be an overlap in drug, so to speak, but it's not necessarily something to be concerned with. So I put that example here as well, where this particular member was at a hospital, or let's say it was a physician even, or an outpatient, received an injection probably of some insulin, and then went and got the remainder, or got a prescription and went and had it filled at the pharmacy. So just based on all of the different criteria that we look at, the units billed, the provider type, the code, the paid amount, and things like that, the date span in between, we are able to bring up to our client truly what we think should be pursued in terms of getting some recovery back. And I just wanted to show here, just to sort of emphasize the importance of understanding how medical claims are billed versus how pharmacy claims are billed, because they're quite different, especially when it comes to injectables. But again, just to outline here, you know, the HCPCS code has a unit of 10 milligrams. The unit of measure for an NDC for this particular drug is in mLs, not milligrams. So there can easily be some billing errors, billing inconsistencies for sure, and we see that a lot even on our audit and cost containment side. When we're auditing purely for the sake of recovery, we see this quite frequently. So just wanted to give an example of how the differences can be between the pharmacy and medical benefit. And then as you saw in the examples, I mean, there can be, you know, just realized savings from an actual recovery. There can be improved processes by training with providers, training with your specialty pharmacy, for example, on prior authorization and things like that. It can allow for steerage once we start looking at your data and understanding what are the providers doing, what are the pharmacies doing. Could you potentially steer a member to not just a more cost-effective way to get their medication, but obviously it would still be safe for that member. But for example, can they get a drug at a home infusion setting, or you know, versus an outpatient? Because we typically see that a lot, where outpatient typically bills at a percentage, is paid at a percentage of bill charges, whereas home infusion is going to be, you know, a percentage off AWP. So significantly less costly to the health plan for that member. So in summary, some of the key takeaways we have for you, obviously the concern about not just opioid abuse, but all drugs. The abuse, the collusion is still of concern. CMS or the OIG, you know, basically summarized the two main issues are that the medic and the CMS need to more effectively collect and analyze data, and they have to have better oversight. The growth in all of these drugs is going to continue. We all see the statistics on the growth in specialty drug spend. It's becoming astronomical really at this point, so it's definitely of concern. But understand your pharmacy and member network, and the key is to monitor that frequently and routinely and be proactive with it. Data can be very powerful, can be very overwhelming. It is constantly changing. And so, again, analytics is a term that's sort of thrown out there, and a lot of folks use it, and a lot of it's effective, and a lot of it is, you know, not necessarily meaningful or actionable. So, you know, CMS and the medic publish a lot of great information. Sometimes, though, it's in arrears or somewhat retro. So Your data tells your story, and if you can, even if you start small, whether you use a vendor or you have your own team, it's important to start somewhere, even if it's with a group of drugs or a group of members, to at least start to understand what your network looks like. And then finally, just to wrap up on some of the, I guess, good news things. I mean, it's not all gloom and doom. There are a lot of things that are moving in the right direction. Based on that report, they've already established some changes. CMS is starting to share what they get from the plan sponsors. The medic now has access to Medicare Parts A and B claims. We also were asking for that for a long time. Just from the death perspective, that's a big one. CMS now requires the plan sponsors to identify invalid prescribers. That's another big chunk. That's an easier thing said than done, because that's a difficult thing to identify. But it's providing data now on excluded providers, starting to recoup payments on claims that have been submitted for deceased beneficiaries. So that's all things that are positive. Folks have started strengthening their edits on the refills of a Schedule II. Now the medic can directly request information from pharmacies. There seemed to be a lot of red tape and gridlock there, and I think a lot of that is improving finally. So again, for those of us involved way back, we're starting to see a lot of the things that we'd been asking for. A lot of you probably see there's a lot of the new opioids coming to the market are abuse deterrent, so that is helping. I guess on the bad news side, they're leaning back now to off-prescription drugs like heroin, so we'll probably see that back and forth, but I think that's a good news thing. E-prescribing, for those of you that don't know or are not aware, is now legal in all 50 states for Schedule II controlled substances. It's been for all, but now for specific for Schedule II. So as an industry, we should really all be taking advantage of that by educating your providers or even certain groups of providers, pain physicians, the autoimmune type physicians that are prescribing some of these medications, to encourage them to e-prescribe. They're a little bit fearful of it, to be honest. But physicians will tell you once they do that and have that available, they start to like it. It's not listed here, but the state DEA databases are also helping tremendously. So a physician can quickly see if someone who comes into their office recently already got, OxyContin, for example, they can quickly see that. I think that's a really fantastic move by some of the states who are doing that. There's a trend we've seen with some of our clients that just based on everything that we've identified or they've identified, physically reviewing some of these pharmacies that apply to be in the network has proven to be pretty effective. In some of the ones that we do, where a pharmacy applies to be in the network, they call and ask us to go visit that pharmacy. Just, are they even open? Do they have their policies and procedures in place and things like that? And right now we're trending at about 50% where they're not admitted into the network. So it may be a little bit costlier on the upfront side, but on the back end you're going to be saving tons of money with that pharmacy not being able to falsely bill or commit fraud. So we think that that's good news. And then I listed the sources here and references of the presentation. The two OIG reports are honestly very fast reading, a little bit interesting reading, so you could Google these and get them. If not, feel free to email me. I'd be happy to provide those to you. But they are nice to read and nice to share. And then that leaves us with questions and answers. So Michelle?
Great. Thanks, Rena. Great information. And on those OIG reports, we can also send the link out. There's been a couple of questions of folks asking about the presentation and recording, so that will come as a follow-up after the session today once the recording is available. So just a reminder to everyone, if you have questions, please submit those through the question panel in the GoToWebinar module on the right there. And because everyone is in listen only. We have a couple questions that have come in, so let me start with those and we'll get some more hopefully here that as folks are submitting. One is, Rena, you spoke to and showed quite a bit of detail on these different report cards and the pharmacy report card specifically. Can you talk a little bit about the customization options for the report cards and the scorecards? And then in conjunction with that, the type of data that is pulled in today and what options there are for additional data points.
We can certainly customize. For example, that new billing was a client ask. They wanted to see, okay, what new pharmacies have come into my network. If, for example, if they haven't had a chance to do a credentialing or on-site visit, they're able to track that type of thing. So it certainly can be customized. Assuming it comes in as a data element to us in the claims, we can incorporate it into the report card. And the way that they sit today, I don't think will be the way they sit a year from now. I mean, things are constantly changing in this industry, and so we want to be able to accommodate and account for those changes as pharmacies and members and prescribers get more and more crafty. We have to keep up with them. So we're certainly able to do customization.
Okay, great. Another few questions here. Does the member drug seeking report include diagnosis codes or any other medical data?
That's a great question. It can include diagnosis codes if we receive it. Typically in pharmacy data where it was derived from, we don't see a lot of diagnosis codes. If it is populated, I wouldn't say it's necessarily reliable because it's being populated by a pharmacy. They might just be picking the diagnosis, for example, for that particular drug, which is a great thing. And I know NCPDP would, definitely is encouraging that. But if it's included in the data, we can definitely include the diagnosis, and that's something that we'd want to do so that you can get a good picture on that member.
Great. Another question here, you indicated about e-prescribing, and one of the attendees had a question where documentation is and what is the documentation indicating that Class 2 meds can be e-prescribed? You can either go to NCPDP has that information, and the organization that I'm looking for the right word, that administers that particular way of prescribing is called SureScripts, and they actually have great training materials. They have training videos that you can provide to a physician, for example, to your team, where they explain in detail how the e-prescribe works and that sort of thing. So I would say NCPDP and SureScripts is probably the best resource to get for e-prescribing. Great. Another question on monitoring compounded drugs with respect to the Medicare guidelines, if you can elaborate on that.
Yeah, we've actually been having a lot of discussion with our clients as it relates specifically to compounded drugs. We'd like to treat that as honestly a separate analytic. There's so much information, even in what we showed you today. There is a ton of data behind what you see. So there's a lot going on in the background when that benchmark reruns, for example, and it's refreshed. So compounds present a whole, we could probably spend another hour just on compounds. But depending on how compounds are submitted and then relayed to us, we can certainly take that information and do some analysis and identify if it's submitted correctly. Is it in line with Medicare guidelines? A lot of times there are some challenges with how that data comes through. It can be, typically we might see the first line in our data that we get from some of our clients versus seeing all of the various ingredients. But it's definitely something on our roadmap to look at and develop an analytic that is unique to compounds. That's a great question and something we want to start to look at too.
Great. Thanks, Rena. I think we have time maybe for one more, and for those that we didn't get to here, we'll make sure we respond to these questions directly. But the last question is, if a member is reported to the health plan, how is that member tracked the next month? You talk about the lock-in component, so maybe just elaborate a little bit about that process.
Yep. So we're working with our clients on developing some specific scenarios of how they would be tracked. So if the member is reported to the health plan is going to take that information and do X, Y, and Z with it. We want to track what that X, Y, and Z is so that, again, it's easy and readable and available for the next month. So, for example, if let's say they were Medicaid and the health plan worked with that member, a prescriber, and a pharmacy to get them locked in, we would want to get that feedback from you to know, okay, they've been subject to a lock-in, and then we would then monitor that member for the next, couple of months and ensure that they're no longer, able to go to, which they shouldn't be, that they're, that we're seeing a decrease in the spend. If they've been identified and there was counseling done or some sort of other intervention, we would want to capture that and have that available specific to that member as sort of a history on that member to be able to monitor them as well.
Great. Well, thank you. We're just at the end of our time. I just wanted to thank everyone. Thank you, Rena, for the great information. Thanks to all for attending and participating in today's session. As a reminder, we will send out that recording link with the information that Rena has covered. And we look forward to meeting all of you at the NHCAA Annual Training Conference in San Diego next month. So have a great day, and thanks, everyone, for attending.
Yeah, thanks, everybody.